All right. Hello, hello, hello. And welcome back. Good to be on the air again. Have Tacuma with me. So that's always a pleasure introducing Tacuma Roeback, our new editor-in-chief for Black Men's Health. So he'll be having plenty of these discussions with us, if not alone, allowing me to not be here so he can do his thing. And with us today, we appreciate Dr. Kelvin Moses being here. Let me give a little intro. I always plan to be brief, but this is a great intro, so I want to make sure I give him his props and thank you for your time and attention, Dr. Moses. So Dr. Kelvin A. Moses, an associate professor of urology at Vanderbilt University Medical Center and the director of the Comprehensive Prostate Cancer Clinic. He is a Phi Beta Kappa graduate of Morehouse College and received his MD and PhD training at Baylor College of Medicine in Houston, Texas. Dr. Moses completed his urology residency at Emory University, followed by a fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center, where he served as chief administrative fellow. His clinical practice focuses on advanced prostate cancer, including several clinical trials, as well as surgical management of advanced renal, penile, and testicular cancer. And his research is focused on addressing health disparities in urologic cancers, determining the role of health literacy in patient interactions with healthcare system and optimal care for patients with, is it metastatic? I got it right, I think. Metastatic or castrate-resistant prostate cancer. With that, we welcome Dr. Kelvin Moses.
Thank you very much. Thanks for having me.
Tacuma, man, jump in. You the new guy. I'm gonna let you lead, sir.
Thank you, John. It's a pleasure to be here with Black Men's Health, talking about such a critical topic. And it's been a pleasure kind of getting to know the work that Dr. Moses is doing in this field as it pertains to Black men. And to start off our conversation this evening, I wanted to get right to it. Dr. Moses, why does prostate health matter, especially for Black men?
Well, again, thanks for having me and appreciate the time to speak with you. Prostate health matters because men deal with prostate issues very commonly. When we talk about prostate cancer, in general, we say about between 1 in 7 and 1 in 9 men will be diagnosed with prostate cancer. And that number is probably even a little bit higher, about 1 in 6 in Black men. And so it's affecting a large number of people. It's actually the second most commonly diagnosed cancer and the number one most deadly cancer, particularly in Black men. And so that's why it's important. The other thing is that a lot of men don't even think about the prostate or deal with it until there's something wrong, until they get their, 30s, 40s, 50s, and maybe the urinary stream slows down, or maybe the erections aren't the same, or, something else is going on. And particularly if men haven't been getting their annual checkups with their primary care doc, they may not even think about it until there's a problem. And so that's why it's important to have conversations like these so that men are educated about what the prostate does, why cancers can develop, and then what can be done about it.
Absolutely, absolutely. And, in talking about that, the fact that Black men, there's a 1 in 6 chance of us developing prostate cancer in our lifetimes. Is there something about our genetic makeup or maybe some environmental factors that predispose us to contracting prostate cancer?
Mm-hmm. So in general, prostate cancer is a disease of aging. So as men get older, the risk of prostate cancer goes up. And probably every man in his 80s probably has a little bit of prostate cancer, but it certainly wouldn't be anything that would give him symptoms or kill him. The risk factors, particularly in African American men, may have some to do with genetics, but if you look at West African men, our cancer risk is higher, and even compared to Black men in the Caribbean, You know, we're all of sort of the same extraction, and still in the United States, Black men have the highest risk of cancer. And so certainly you want to think about genetics, but really environment and stress and inflammation do have a role. Probably dietary has a role as well, or diet has a role as well. If you look at Japanese men versus Japanese immigrants to the United States versus the children of Japanese immigrants, that cancer risk escalates. And so there's something about the American environment, the American diet, sort of the endemic structural and social inequities that are built in to the fabric of the country. They all play a role. And so for Black men, we have to understand that even though we're at higher risk, you can still get appropriate screening and treatment and enjoy your normal lifespan.
You referenced, Dr. Moses, about age, right? Even earlier, before you were talking about, men in their 80s more than likely have some form of prostate cancer. But earlier you referenced some years in there. And one of the things that was pretty much general in the I guess atmosphere, in the sense of, if you're getting to your higher 40s, 50s, men need to start paying attention to that. I think, at least in my kind of sphere of influence, that number is starting to lower. So are you hearing that? What is the number that men should be paying attention to that, specifically Black men? And with that, why has that number started to lower? Is that just because more information, access to data, research, et cetera, or what's going on there?
Okay, so I'll answer the first part first. If you look at the various national guidelines panels that issue recommendations regarding screening, I'll focus on three of them. The American Urological Association recommends shared decision making. So that means a man speaking with his physician about the risk and benefits of screening for prostate cancer, starting at age 55 until age 70 with normal lifespan. They emphasize the shared decision making because over this last several decades, we've noted that not all cancers need to be treated or even diagnosed. And so you want to avoid overdiagnosis, overtreatment. And so that's where that shared decision making comes. If you look at the National Comprehensive Cancer Network, or NCCN, their guidelines recommend starting at age 45 up through age 75, again with normal lifespan. For both of those, AUA and NCCN, they do recommend scaling back about 5 years for Black men due to higher risk. And then if you look at the United States Preventive Services Task Force, USPSTF, which is really what a lot of primary care physicians follow, they too recommend 55 to 70 shared decision making. They don't make any discretionary changes for African American men, but in general, people are recommending somewhat earlier screening. For men who have a family history of prostate cancer, in a father, brothers, or even sons, they do recommend starting earlier as well. In general, I recommend that Black men start at age 45, at least getting a baseline PSA. And then if there is a strong family history, even starting at age 40. And at least get that first baseline PSA. And if it's very low, and really in your 40s, that PSA should be less than 0.5. So if you start at 40 and that PSA is very low, you can wait till 45, check it again. If it's still very low, then you can go to age 50. And then for Black men, I recommend getting annual or every other year starting at age 50. Having a first degree family relative with prostate cancer doubles your risk. And so that's why I recommend starting earlier. As far as scaling the ages back, really it again depends on which panel. It's somewhere between 45 and 55 as far as starting. And that's where the conversation with your physician is important, because if they know you have a strong family history, if you're a Black man, or other environmental exposures, then they can say, okay, you need to start at 40 or you need to start at 45, depending on those risk factors.
And
And that
that baseline PSA, is that again something that men should just be getting from their general practitioner?
They can get that from their primary care doc, and we do recommend that. The reason I say for a baseline, at least in Northern European men, it's been shown that if you're in your 60s and your PSA is 1 or less, your chance of dying of prostate cancer is minimal, gets close to 0, 1%. That data is not known in American men in general, and certainly not in Black American men. But we can extrapolate and say, if you have that very low baseline PSA, that risk is somewhat lower.
Why is that, Dr. Moses? When you said that data is not there in Black men, does that mean we need to be encouraging some kind of study that would help identify some data that would help us learn more about Black men specifically?
It would be nice if we could have a study like that. It's a little bit challenging in the United States because the frequency that testing occurs is highly variable. Black men in general are less likely to get screened overall, and we can talk about that a little bit later. That data comes from Sweden, which has a national health service, which has really only about 3 or 4 major medical centers, and every man is on their health registry. So it's much easier for them to follow data longitudinally. To have that kind of information, to know the impact of a baseline PSA, you need to be able to follow men for 20, 30 years in order to see that difference. So, the horse is probably out of the barn for doing a study like that, unless somebody has a repository of blood from 30 years ago and could do a study there. But certainly when it comes to research and clinical trials and studies on prostate cancer, we really need African American men to participate because that data is important.
Can you talk about what a PSA is? What does it stand for? And what's considered a good PSA score versus a not so good PSA score? What's the threshold?
Okay, good. And what I'll do is even take a step back and just say, what is screening for prostate cancer? So it comes in 2 forms. One is the blood test, PSA, and that stands for prostate specific antigen. And the prostate makes PSA naturally. It actually helps break down the semen so that you can have your fertility. And as we get older and the prostate gets larger, that PSA does gradually rise. The second part of screening is the DRE, digital rectal exam. Put a finger in the bottom, feel the prostate. And the reason for that is that prostate sits right down in the center of the pelvis, just in front of the rectum. And the vast majority of cancers of the prostate are on the back side of the prostate, which you can feel. And so those 2 tests together are what prostate cancer screening is. In terms of a PSA, there's not really a quote unquote normal PSA. We know averages based on age range. We know that in your 50s, your PSA, the average is around 2.5. In your 60s, it's closer to 3.5 or 4. In your 70s, it can be 5 or higher. And those are what are considered acceptable ranges. That being said, a PSA of 6 in someone who's 80 years old doesn't nearly have the urgency of a PSA of 6 in a 40-year-old or a 50-year-old. Those are very different things. The point of getting annual or semi-annual or biannual PSAs is that we can track the trend of the PSA rising. So someone has a very slow, gradual rise over several years, and they get to PSA of 4 or 5. Again, that's less concerning than if someone has been going along with PSAs of 1, 1.5, 2, and then all of a sudden jumps to 4. That 4 is significant to us. And so that would in our minds mean that, maybe there's something concerning and we need to investigate further.
Absolutely. And that kind of speaks to the nature of prostate cancer that I had a question about. It seems to have this really insidious nature in that it's slow growing, it's present, slow growing. You don't necessarily feel the effects of it until it becomes advanced. Can you talk about why that is and why that's a problem, particularly for African American men?
Mhm. So in general, yes, prostate cancer is a slow growing cancer and tends to progress through different grades of aggressiveness. The prostate and prostate cancer is a hormonally based cancer. So it feeds on testosterone, which we naturally produce. It usually does not have symptoms because it is on that backside of the prostate. It is deep in the center of the pelvis. So unless someone has an enlarged prostate, just benign enlargement that's causing urinary symptoms, you would necessarily have symptoms from localized prostate cancer. The issue is if you don't want symptomatic prostate cancer because that means it likely has already spread or metastasized. And there's not a cure for metastasized prostate cancer. There certainly are treatments available and you can manage it and men can live, potentially years with it, but there's really not a cure. And so that's why we encourage screening, because you can achieve cure if that cancer is localized and caught at an earlier stage. For as far as specifically in Black men, because men tend to present with more aggressive cancer or higher stage, that growth rate may be a little bit faster in Black men. And so again, that really just reinforces the need for early screening and at least annual or biannual screening.
So timing speaks a lot to this, right? You spoke about in the sense of a 4, at one part of your life might be very different than a 4 at, a younger part of your life. And then you just reference also timing in the sense of, again, if it jumps and timing is important in the sense of catching it at the right time, especially if it's too late. So having it earlier and being able to have more data and be able to track that in case the levels change is very important. So when you said biannual, did you mean twice a year or every other year?
Every other year. So for men who truly have a low PSA normal exam, a lot of the guidelines will say okay to do every other year.
Got it. So that's just something we need to be encouraging brothers to get started earlier, at least 45 or so, and make sure it's happening at least every other year.
That's right.
Okay.
That's right.
You referenced earlier, you said about screening and some hesitancy in Black men being screening. You said you wanted to talk more about that. Please
Yeah.
do so.
So I'll take it from two ends. On the healthcare side, there's data that shows that Black men are less likely to receive screening for prostate cancer. And that is an endemic problem. That is an access problem, is probably some sociocultural barriers that contribute to that. On the other side, yeah, there is hesitancy. Black men and most men, right? They don't want somebody's finger up their butt, and they, and men in general, are not quite as aggressive about seeking out their own health care compared to women. And so there's a little bit of denial, and as we get older, sometimes the realization that these things are occurring can be upsetting or unsettling. My former chairman, when I was in training, he used to say, all men are immortal until they turn 50. And there's some truth to that, because that's when a lot of men do sort of re-enter the medical system just because they need to get their blood pressure checked, or sugars, or cholesterol, or cancer screenings, or any of those things. And so that's why there's probably a lower rate, less likely to get screened, but also some hesitancy about getting tested.
I thought that immortality was up until 30, when you get out of bed and start feeling something. You're like, what is
Yeah.
that? You don't know. Come 40, you're like, oh, I know exactly what that is.
Yeah.
These joints going on, and back starting to feel things. So,
Right.
but Tacuma and I have spoken about that in the past, in the sense of just, it not being as normalized for men going to the doctor, men in general, right? I have found in the work that we've done in Black men's health that a lot of men can be very indifferent about their health, right? They know they should be doing better and could be doing better, but again, it's just not normalized as much as women, right? Women have some specific reasons that they're going to the doctor every year. So I think kind of culturally it makes sense, because all the women are doing it.
Mm-hmm.
Again, to your point, access and environment and things of that nature, but hopefully they're in a scenario where they're doing a lot of things annually. So this is it's a normal thing that they're going to the doctor every year. And
Right.
for men, again, especially when you talk about the not reaching those ages of immortality and thinking you're just bulletproof, I think it's easy for men to go a long time and it not be something that they need to do, or they don't believe in their mind they need to do. And we got to start having those discussions. It's interesting, before Tacuma and I even start about talking about Black men's health in the sense of what we're here talking about right now, the entity in a sense, and us, creating, focus on creating more balance through health for men of color. We have been talking about health as Black men and one to another, and really checking in on each other. Too. I don't know if you remember that. Like, hey, when's the last time? Like, make an appointment, right? We speak a lot about Dr. Moses that this discussion is not an arm around the shoulder, but more like a poke in the chest, right? I mean, these are serious matters that that we need to pay attention to, right? We have families, children to raise, and at least in our case, wives to protect and cover, and uplift, and communities to build, and legacy to leave. And we have to take this matter very serious. So when you're talking about screenings and getting checked and providing some consistency in our life for sustainability, those are discussions we need to continue to have.
Yeah, absolutely. Absolutely.
I was on mute, excuse me. That goes into my my next question. Like, if somebody gets an abnormal reading, or there's a strong suspicion that prostate cancer is present, what advice would you give them to handle that? Like, what's the next step? Can you talk about, even from a mental standpoint, of how they can handle that situation?
Mm-hmm. So there's a few things to consider. Number one, is it as I talked about, you're trucking along with the normal PSA and it all of a sudden jumps, or is it slowly escalating to that number, or is it the very first one? If the number is elevated and not like a crazy number like 100 or 1,000, you can actually repeat it a few months later just to see, is it related to infection or inflammation, or is it truly an elevated number? And some men can have elevations due to infection or inflammation, not necessarily feel it. You certainly want to get some blood or urine cultures to confirm if there's truly an infection. And there's other reasons it can be elevated, and your physician can talk to you about, if that contributed or not. But if it is high, then you want to get engaged with a urologist, because if it is elevated, you probably will need to get a biopsy of the prostate. And a lot of times we'll even recommend getting an MRI because an MRI can give such good anatomic detail. You can actually see abnormalities in the prostate that you may want to target on the biopsy. What men should do though is not freak out. Okay, that one elevated PSA value only gives us an indication of what might be going on. So you still want to have that conversation with your physician, with your urologist. You can even get a second opinion if you want. And then once the biopsy results come back, again, it's not the time to freak out. Okay, even if there's a cancer, we need to know what grade it is. Is it low grade and something that can be watched safely? Is it higher grade? Do you need to get further imaging? Even in the worst circumstances, I tell men if they show up with metastatic disease right off the bat, you can still live years. There's some work that has to be done, but it's typically not an immediate death sentence. It's very rare where someone's come in with metastatic disease, unless it's just, so widespread, there's not much to do about it. But I've had men come in with, very symptomatic from metastatic disease, and we do hormone therapy, and they're feeling better within a couple of weeks or a couple of months. And so, that mental health aspect of it is, take it in stride, educate yourself, talk with your physicians, learn about your options, and understand that there's things, treatments and therapies that are available for every stage along that spectrum.
That's a valuable that speaking about educating yourself and having that mental health aspect of it, so you're not spiraling down a hole, like you said, thinking the end is here.
Mm-hmm. Mm-hmm. Yeah, it's important. And I've never had cancer, but I've certainly have given people a cancer diagnosis. But what I tell them is I can empathize. I understand. You hear that word, and oh gosh, you think about the worst scenario, right? You think about a family member, or you think about something you saw on TV or a movie or whatever. But that's where the education part comes, because you need to get accurately staged. You need to know what your therapeutic options are. What is the true prognosis in terms of timing? And so once you get over that initial shock, that's where that learning phase comes in.
Indeed. Go ahead.
Well, so we talk about the range of treatments, and part of the hesitancy I sense among Black men are some of the side effects and outcomes from treatment, which are pretty unnerving.
Mm-hmm.
Can you talk a little bit about how real those side effects are with prostate cancer treatment?
Mm-hmm. Well, they're absolutely real. And there isn't a treatment that we've come up with yet that has no side effects at all. If I ever come up with it, you can come visit me on my private island, because everybody's going to want it.
Yeah.
But when the range of therapies for prostate cancer go all the way from what's called active surveillance, meaning you don't get active treatment for it, but periodic PSAs, repeat biopsies, imaging, things like that. It goes through surgery or radiation, or sometimes a combination, all the way to hormonal therapy for metastatic disease. What people think of commonly are the side effects from either radiation or surgery. And like you said, it's a real thing. And people are dealing with erectile dysfunction as a result of therapy, urinary function, urinary continence as a function of therapy. And if they're on hormonal therapy, your testosterone is drained out of you, and that's that male life force. So your energy, your libido, your sexual drive, your muscle strength, hot flashes, all of that comes along with hormonal therapy. And so the types of side effects that you can have can be specific to treatment. So if you do get surgery, erections will be affected and urinary continence will be affected. Fortunately, at least for urinary incontinence, total incontinence is actually relatively uncommon. it is a function of age. So the older that men are, if they have surgery, the more likely they are going to have some continence issues. Younger men typically can get back to being continent, meaning dry, maybe a safety pad in their underwear if they're going to be out for a long time or playing golf or something like that. Even in the totally incontinent man, though, there are treatments for that, including surgical treatment if necessary, to get back to being dry. As far as erections, when it comes down to surgery, it is a function of age. It's a function of your function before you have surgery. So a lot of men think that they're playing pool with a stick, and some of them are playing with a rope. And you got to be honest with yourself. What are you bringing to the table? Again, younger men tend to do better with recovery of erectile function. I would say most men need something, medication, in order to have adequate erections for function. And the older you get, again, that recovery of function is less. With surgery too, there are maneuvers that you can do to try to spare those functions, both urinary and sexual. And that's what we would call a nerve sparing approach. The nerves that aid in erectile function and probably with your continence are literally sitting on the surface of the prostate. And even if you can do a complete nerve sparing, there's going to be some effect because you're touching those nerves. But that goes back to what we were saying about screening and earlier detection. It's much easier to do nerve sparing if someone has very early detected cancer. If someone has aggressive cancer that's outside of the box, you can't do nerve sparing. For radiation, continence and erectile function typically aren't the biggest issues. Really, it's more about the effect on the bladder and rectum because they're nearby. Some people will get some irritation or inflammation of those. That typically recovers after you've completed treatment. Long term, there are risks, secondary risk of bladder cancer and colorectal cancer, and even lung cancer. Those percentage increase is very small, but it is a little bit higher compared to the general population. And then I talked about hormone therapy. Again, those risks are libido, loss of muscle function, loss of bone density, hot flashes, and then even long-term risk of cardiovascular disease or diabetes. And so for the men who I put on hormone therapy, we really go over lifestyle improvements that they can do to try to reduce or remove that risk of metabolic complications.
What would you say? I mean, that's quite an intimidating list right there. What would you say to a man who's discovered he has prostate cancer and he hears about all these side effects that come with treatment, and he says, you know what, I'm good. I'm just going to try to live with it. I don't want to lose like my erectile function. I don't want to experience incontinence or all the other associated side effects with various treatments. What would you say to that guy anyway?
Well, a lot of it depends on their stage. As I said, people with early detected disease, you can avoid treatment because they're unlikely to die from prostate cancer or even have symptoms. For the man who has higher risk disease or even spread to lymph nodes or metastatic disease, what I would say to them is, well, let's make a priority list. And it helps if they have, their spouse, significant other, friend, girlfriend, boyfriend, whatever, because that other person can help them make that priority list, and I say, from my perspective, my priority list is cancer control, right? I want to try to cure or at least control disease. I want you to remain continent, right? Because I don't care what kind of erections you have. If you're leaking urine all over the place, nobody's going to let you use that erection on them, right?
Right.
So I want them to be dry and then deal with erectile function. And what I tell them too is if I can get disease under control, then I can help you manage continence. Okay. If we have to do a sling or a cuff in order to implant to get you back to dryness, we can do that. Same thing with erections. I can get a man back to erectile function. Now, some men it may require medication, some men require injections, and some men might need a prosthesis, actual surgical procedure. But I can get you back to erectile function too. So that's what I tell men. Let's make a priority list. What's important to you, and then we'll talk about the type of treatments that are available to you, and then we can discuss, what specifically are your risks. And again, that goes back to their age, their pre-treatment function, and what treatments they do have available to them.
Dr. Moses, what is something that's just frustrating for you in the sense of the work that you're doing and, seeing maybe things not moving in the direct with more access to information and things of that nature? What are some things that are frustrating to you, specifically as a Black man looking, this outlook for Black men and some of the things you spoke about in a sense of some of the us being first in the worst in certain areas.
And that's my biggest frustration is why do we have greater than double the risk of dying from prostate cancer compared to white men? And that is something that I've done research, I've given talks, I've written papers, like that to me is the greatest frustration, because we can achieve equality, but it's going to take changes on multiple levels. Okay, it requires changes in access. Okay, so on a federal level, ensuring patients, making sure that they can see a physician, giving them access to care. On a healthcare systems level, making sure that you have culturally competent and diverse physicians to see men and Black men, Blacks in general, but certainly Black men have a well-deserved distrust of the medical system because of things that have happened historically and personally.
Indeed, right.
So that needs to be addressed. Education, right? So even just on the patient level, educating yourself about prostate cancer and your overall general health. But that mortality gap, it really comes down to screening and treatment. And the reason I say that is because in systems where there is equal access, like in the VA and the veteran system, you actually do see a very narrow gap or maybe no disparity at all, because every veteran has access to healthcare. They have access to screening. They have access to treatment. And so you can get some of these equivalent outcomes if men are screened and treated appropriately. So that's really, that's been for the last several years is my main job. I enjoy in doing talks like this for men and for Black men especially. But I've been more focused on talking on the healthcare administration level and advocacy and research and clinical trial designers. How do we make sure to include Black men in the thought process?
Right.
That's where I think we're going to make the biggest difference.
Yeah, even when you spoke about, having folks that are culturally competent, it starts with having more presence and representation, right? I mean,
Absolutely.
It's easier to be culturally competent if you are of the experience.
That's right. That's right.
You referenced diet earlier, even when you were speaking about, people that might not have been born in America, but then having children that are born in America, those numbers are significantly different. So talk to us about diet. What kinds of things should men be eating, not eating, eating more of, eating less of? Talk to us, sir.
Yeah. So, what's good for your heart is good for everything. And what I tell men and the recommendations from nutritionists and dietary specialists is reducing the amount of processed foods. So that's packaged foods, things that can sit on the shelf for 5 years that you can still eat. Like that means it's been highly processed. You know, deli meat, sausages, all those types of things are highly inflammatory. And inflammatory food causes DNA damage, and DNA damage can lead to cancer. And so, what you really want to be eating are more fresh fruits and vegetables, whole foods, right? Not cooked to death. Avoiding fried foods as much as possible. Reducing the amount of red meat that people eat. Increasing the amount of water people drink. You'd be surprised how many patients will come in and be like, I don't drink water. And I'm like, ever? They're like, no. They drink Coke or coffee or something, but they just don't drink water. Limiting alcohol. I never tell people not to drink it unless they have a problem, but certainly you want to moderate that. Avoiding tobacco, smoking as much as at all, or as much as possible, or certainly quitting smoking. All of those things contribute to inflammation. And if you add on stress on top of that, and you add on racism on top of that, or you add on lack of insurance, it's all sort of a toxic combination. So that's what I say about diet. Don't add more salts to your food. I've got relatives and friends, they'll get a plate of food and before they even taste it, they're already shaking the salt on. Like, wait a second,
Yes.
it might be okay, So those are the recommendations. And when men come to me and they've been diagnosed with cancer, I really try to have them decrease the amount of simple carbohydrates. So white bread, pastas, cookies, those type of things. Really try to
Tacuma, like
moderate,
everything he's listed.
moderate.
I mean, he got the cookies. I mean, I heard him on the red meat and the, I heard him on the red meat and the processed food and all that, but he got the cookies. I mean, come on, man.
It's
Cookies, lasagna, all the great things in life.
All the great things in life.
You gotta moderate.
Everything in moderation. That's right.
And the thing is, there's a lot of healthy substitutes out now. So for pastas, there's pastas that aren't made with flour that you can eat. Yep. There's meats, lean meats. You can eat turkey instead of beef, or now they have the Beyond Burgers or Possible, where it's a plant-based meat substitute. It tastes like it, looks like it, smells like it, but doesn't have that saturated fat and cholesterol. So, look for healthy substitutes for the things. You really don't want to have such a radical change to your diet where you can't stick with it.
Right.
You really want to kind of, maybe if you drink 4 sodas a day, maybe go down to 2 sodas and drink water instead.
Yep.
If you eat red meat every day, maybe switch it out for a meat substitute, a couple of days a week. If you love rice, there's rice substitutes now. If you love adding salt to your food, there's non-sodium salt. So like just little things where you can make adjustments and make substitutes where you're more likely to stick with it.
Dr. Moses, the thing that's so important about what you said, and excuse me not to offend at all, but I say sometimes this interaction with, white coats, right, with, medical professionals or even academics, sometimes the discussion is really wanting to move men from where they are to 10, which is sometimes 0, right? Yeah. And going from 0 to 10 is difficult for anything. Yeah. But if you can get somebody to 1 or 2, maybe you can start to get them moving in the direction of 4 or 5. And even 2 is better than 0, and definitely 2 is closer than 10. So I love what you said about just incrementally, right? Not trying to have somebody go from, couch to marathon. That doesn't make sense. Right. Just get them active. And then even it's amazing, eating, water, and running. I have found that the mind and the body can start to talk to each other. And it's amazing what your mind and body can overcome together. especially when your mind doesn't think that it's in crisis and you're going to die. You know, I mean, it's really, Tacuma, we're going to have a whole discussion about water. I mean, we might, you know, bring Dr. Moses back on to talk about water, because that's a whole discussion, like psychologically, and just, you know, I have found Dr. Moses, I was fasting at one point and started drinking a lot of water. And I found some ways to make my body really desire water when I got thirsty, as opposed to I'm thirsty and looking for some other substitute, like there's the lemonade or the ginger ale or, you know, whatever. That those things I like also, but really having my body, you know, really desire water. Like that's what it's trying to quench itself with water. Like water is the thirst quencher, not something else. But that's a larger discussion, because you're right. Some people, they don't want that at all.
Just don't drink it. I mean, they'll talk about water like it's you know, poison. I don't drink water.
Those are large debates about what water tastes like also. And I know, don't get me wrong, I know in different parts of the world and different parts of the country, even, you know, things taste differently. But to me, like water is water. And it's not something that tastes amazing. It's just water, but it's necessary.
Yeah.
What about you know, anything else you want to say? We don't want to keep you long. We've kept you long enough, and we know you have much to do and a hard stop coming up. But anything else that you like to share with men, and anything with the Black Men's Health audience?
Well, so I'll do one specific topic and then sort of a general wrap up. I know Tacuma mentioned before in another talk we had about environmental contribution, and there probably is. There's definitely the generation that we're seeing now. The older men are in that Vietnam era, and a lot of were exposed to Agent Orange. And there is definitely an association with Agent Orange and prostate cancer, among other health issues. And so that's something important. I do ask men about that. What were their exposures, especially in their younger years? What I would say in general, though, is that if you're tuning into this, you've already taken that first good step, right? Like you're already learning a little something. You're already kind of doing that investigation to get to health, good health. The other thing, get a primary care doctor, okay? Like get that annual visit, get your screening test, get your blood pressure check, get your sugar check, get that colonoscopy done, get your PSA, you know, all those different things. Because your primary care doc is like the conductor of the orchestra, right? They can send you to different specialists if you need to. They're watching over the different parts of the body, and should also address, you know, mental health. You know, are you doing okay? Are you sad or whatever? You know, that primary care doc is very important. And then another thing, as I said before, is what are your priorities in life? If you've got kids, you want to be around for them. You got spouse, friends, family, job, whatever it is that keeps you going every day, you know, focus on that, because when it comes down to hard decisions, it's very easy to think in a narrow thing like, oh my God, I'm never going to have an erection again, or I'm never going to do this again. And sometimes you have to back away and say, okay, let me think about my wife. Let me think about my kids. Like, what do I need to do to be around for them? And then work on all the other issues that come along. Getting that annual screening, you know, is simple. Just get it done.
Tacuma, anything for you, brother?
I think, thank you, Dr. Moses, first of all, for your time. I think that's a perfect way to end this, especially talking about the importance of having a primary care doctor and the relationship of prostate health to total wellness, which you alluded to there. So, you know, thank you very much for your time.
I do have one last question, Dr. Moses, because you spoke about access earlier. You just spoke about, again, to Tacuma's point, the benefit of, you know, having primary care, you know, physician and that person being an integral part of your life to help conduct all things that need to be, all the trains that need to be moving in the right direction that might need to support you outside of that primary care physician. What if, you know, especially again, back to access and speaking about environmental issues, what if men don't have that ability right now? What if they don't have primary care? What if they, you know, don't have insurance? What steps can they be taking? What steps should they be taking to make sure that they can take best care of themselves?
Yeah. So there are safety net health centers. And if you're in a bigger city, there's usually some sort of county hospital or public facility or underserved clinic. And then even in rural areas, you know, community health centers do have coverage for men, completely uninsured men or anybody. There are resources, and it's really just as simple as either going to a community health center or even getting online. There are insurance available through Affordable Care Act. You just get on healthcare.gov. Not all states participated in the Medicare exchanges, so if you're younger, it is more challenging. But there are resources, and there's social workers at safety net centers that can help get coverage as well. A lot of it, unfortunately, doesn't rely on employment, and so if you are employed to get insurance through your work, that's great. But if you're unemployed and not on disability, that's where it will take a little bit of work. You do have to find, again, either get online or go to a safety access center in order to get that health care. But everybody deserves good health care, okay? And if you have to put in a little bit of work, that's okay, because if your health is your health, it's worth it.
Indeed. Well, we're here again, Black Men's Health, discussing why your prostate health matters. We thank you so much, Dr. Moses, for your time and attention, sir, and all the wonderful insight and wisdom, and as well as spending some time with Tacuma earlier. We'll make sure that we have more information for our audience and anybody that wants to find out more about prostate health on the Black Men's Health website at www.blackmenshealth.com. And we welcome you back, sir. We love to circle back, even if it's just about a debate about water.
Okay.
And cookies. And cookies.
And cookies, that's right.
Thank you so much for your time, sir.
Thank you, Dr. Moses.
Thank you very much.
We appreciate you. Respect.